And today on the Leadership Forum is all about leadership and health, and we're turning our focus on cancer and palliative care as well. And we have doctors who are coming all the way from India, and of course also we have our own here in the country. And these are the issues that we want to drill deep and look at keenly, because we know the burden that cancer has actually saddled so many wananchi, all the citizens with, and of course the exorbitant cost of medical care when it comes to cancer. Today is an open forum for you. We have the doctors also here who you can call in, ask questions, share your contributions with them as far as cancer is concerned. And this doctors also from Apollo Hospital in India, where they are opening Apollo Hospital Information Center here in the country, where you can get all the details about Apollo and the initiative in the country, and why they're here in the country, and why they're opening this particular information center, what is their collaboration with the government, and of course we also will know what palliative care is all about, and how also the country is struggling to make sure that people who are suffering from cancer and other communicable diseases are catered for as well. Allow me to introduce to you this morning our panelists who are already here. We have Professor Peter Mungai Ngugi, who is a urologist, also is an associate professor, Department of Surgery, University of Nairobi, and as mentioned, a consultant surgeon and urologist at the Kenyatta National Hospital. Also we have with us Dr. Zipporah Ali, who is a medical doctor and is currently the executive director of Kenya Hospices and Palliative Care Association. Also, we have doctors from India, and I will go one by one by mentioning their names. We have Dr. G.K Jadhav, who is specializing in radiation oncology. He's a radiation oncologist, Department of Institute of Cancer, and he, of course, will give you all the full details of them when we will get their profiles and when they will speak to us on the lectern. Also, we have with us as well Dr. Sujit Chowdhary. He is a pediatric urologist and a pediatric surgeon. We'll give you all the gritty details of him as well. And we have as well, did I mention Dr. G.K Jadhav? Right, who am I missing?
Sanjiv Jasuja.
Oh, Jasuja. Yes, just tell us more about you.
Yeah.
I seem to have mixed up my papers here.
So I'm a nephrologist.
Nephrologist.
Kidney specialist.
Right, nephrologist.
Kidney and transplant specialist, yeah.
Fantastic. Thank you very much. And just maybe to set the tone going, we'll be hearing from you. And we have our lectern there, right? And we have our camera there. I'll give each of you 5 minutes to talk to us on how the menace of cancer, and why also you're here in the country, and why Apollo is taking particular intent on coming up with the information center here in the country. Most of you and most of Kenyans, we know that they've been coming to India for medical care. Why is India, first of all, the highlight and the destination for medical tourism, right? Is it something that we can learn from you, or what has been also a secret, the secrets of success as well? So how we do it here on the Leadership Forum, every Friday we give you a chance to walk to the podium and talk to Kenyans. And you can realize you have your mic, or you realize you have your mics, but there is another mic awaiting for you on the lectern, so you can walk to the podium. I'll give you that chance to walk to the podium. Then I have my bell with me. This is just to make sure that we keep time. Also, I have my yellow card and my red card. So if you're a fan of Manchester, this is not for you, or Arsenal, right? It's not about football, but this is just to make sure that we're keeping time. So if I raise the yellow card, it means you are midway, right, through your time. If I raise the red card, it's actually just to warn you that, yeah, you're supposed to be winding up. If you go overboard, then I'll ring the bell. If you refuse to actually get out from the lectern, I'll come now and shove you off. Thank you very much. But let's just, before we go to hear from what you have prepared for us briefly, right? And Dr. Zipporah Ali will tell us how also it has been a challenge for caring, people who have communicable diseases in the country, and how cancer also is ravaging the country as well. And we can hear also from Professor Mungai Ngugi to tell us more how also, you know, we will discuss different sort of cancers, but the key pivotal, I think, cancer that is really ravaging the citizenry, especially of Kenya, one will be prostate cancer, and the other will be also breast cancer as well, right? So I think I've laid the groundwork, right? But we want just to discuss, let's hear first of all from our doctors from India. Why here in the country? Let's begin with you. Dr. G.K.
Yeah. G.K Jadhav.
Yeah. G.K Jadhav.
Yeah.
Yes. Let's begin. So why is Apollo particularly interested in opening an information center in this country?
You see, in the past few years, ever since we have been visiting this country to see patients and patients coming over to India,
yes,
there has been a lot of confusion amongst the patients as to whom to approach, which doctor to approach, which department to approach. So we thought it is better we open up an information center which can guide the patient in the correct way, where to go, when to go, and you know whom to contact, who's the contact person or the contact doctor in Apollo once you land up in Apollo Hospital or in India. That is the idea behind the Apollo Information Center. Plus, what are the facilities available with us? We have everything possible available in the medical field. All state-of-the-art technology, robotic surgeries, bone marrow transplant, the best of medical oncology care, palliative care. I'm so sorry about it, but we cater to everything.
Yes.
Plus, we have something called as a backup facility from all departments, like the nephrologist, the cardiologist, the urologist, etc., including hyperbaric oxygen. Probably very few centers in the world have even hyperbaric oxygen, where you require during cancer therapy or after cancer surgery when the wound doesn't heal.
Yes.
We make use of hyperbaric oxygen, that is, you are putting in oxygen at high pressure, so there is a good blood flow into the wound and there is a proper wound healing. We have everything. You name it, we have it. And that is what people do not know about the facilities available with us in Apollo. That is the reason this information center has now crept up in Kenya, or rather Nairobi, to lead the patients or guide the patients in a proper way.
All right, maybe for the benefits of our viewers, you know, we might be assuming that most of them, they understand what a nephrologist is, who's an oncologist, a pediatric surgeon, or a pediatric oncologist as well, who is a urologist. You know, so many of his names, maybe they don't really relate with our viewers, and what also is palliative care as well, right? So maybe we can begin also with Dr. Zipporah. First of all, talk to us, what is palliative care? When we talk about palliative care and Kenya Hospice, what do we really mean?
Oh, so okay, maybe in simple words that everybody understands, palliative care is care that's given to patients with life-threatening illnesses. And sometimes people say incurable illnesses or terminal illnesses. When somebody has been told they have cancer, for example, or even they have HIV or they have advanced diabetes and the rest, they will, of course, need palliative care. It is a service that actually focuses on the quality of life of the patient, improving their quality of life, mainly by addressing issues of physical symptoms. And for cancer, pain is a very common symptom. About 80% of the patients really have very, very severe pain that needs very special medication to control it. There are many other symptoms, you know, with diseases, but I'm just focusing on pain because that's one of the symptoms that we tend to ignore when patients come to us. So it focuses on the physical symptoms of a patient. It also focuses on the psychosocial issues, emotional issues, you know, even spiritual issues as well, because it's actually a holistic approach that looks at the whole patient and not just at the disease. It looks at the comfort of the patient and also of the family members of the patient, because if you have a patient who has got cancer in the family, even the family is very devastated. They do not know how to take care of this patient. They are worried. Their concerns are, their financial concerns, their spiritual concerns. So all those things are really part of palliative care. And if a patient were to die, it also extends into bereavement services for the family members. But what I want to emphasize is that it's a service that should be given from the onset of an illness.
Yes.
Unfortunately, clinicians in this country, for example, wait until a patient is advanced and refer them for palliative care. I'm not talking about hospice care. Hospice care is part of palliative care. It focuses a lot on end-of-life issues, but palliative care is supposed to support a patient from when you have a diagnosis to whatever journey the disease will take.
Right.
Yeah.
Dr. Sanjeev, when you talk about a nephrologist, who is a nephrologist?
So, nephrologist is a kidney specialist which deals with largely the kidney disorders plus kidney transplants, dialysis, peritoneal dialysis. These are the main key domains which a nephrologist looks after. And quite a few of nephrologists like us have developed a key area into the critical care of nephrology, which is largely practiced into the ICU cares.
Thank you. Let's hear from Dr. Chowdhary as well, a pediatric oncologist.
So I'm a pediatric urologist and a pediatric surgeon.
All right, urologist.
Yeah.
Okay.
So about 3% of babies who are born will be born with abnormalities of the urinary tract. And they will manifest at different stages of life by different symptoms. And typically in the developing world, by the time they develop symptoms, the chance to cure is lost. So provided the clinician picks up these conditions at the right time, most of them are correctable. Most of them are correctable by endoscopic technique, and most of them are correctable by the laparoscopic technique. The purpose I'm here is to share with you the current developments in our specialty, which does not exist anywhere else in the developing world. We are able to treat children with complex malformations of the urinary tract, GI tract, without opening the abdomen or the chest of the child. And this facility is available only in the US and Europe and Australia at 10 times the cost that a patient has to pay in a hospital like ours. So for example, for the African continent, your most developed medical center is Cape Town. And with great pride I can tell you, as a member and a citizen of the developing world, that Cape Town actually is behind us in what we are able to deliver at Apollo New Delhi, as Dr. Jadhav has been sharing. In the last 15-20 years, the way the Indian medicine and surgery has evolved, we are the first large center outside US and Europe with huge volumes of robotic and endoscopic surgery. And particularly for a child, if you are a parent of a child who's diagnosed to have a disease or a surgical condition of the abdomen, either related to the urinary tract or GI tract, your biggest concern is, what about the pain to the child? What about the period of hospitalization? What about complications? What about surgery for failures? So once again, with great pride, I can tell you that we do about 650 cases a year with less than 1 or 2 mortalities, which is less than 0.1% mortality, which is quality standards that is present in Europe and US. So we have come to share what we do and how it relates to the Kenyan patients.
All right. And of course, we can learn experience sharing from you as well. We are well full steam ahead in terms of technology. You say without, insertions at all. This is through LESA?
Sorry?
Through the LESA technology?
Yes.
Okay, you'll be telling us more about that. All right, let's hear from Professor Mungai Ngugi, a urologist. He's a pediatrician urologist and urologist. What is the difference? Of course, this is for the children.
Urology is the science of dealing with the parts of the body that relate to production of urine, transmission of urine, and the exit of urine. For the male system, it also deals with areas of fertility. So it is that which allows urine to be delivered from when it is formed. So the nephrologist deals with urine up to when it is produced. And the urologist deals with the delivery of urine to the outside. And
so he carries the baton and we pick it up from the...
Yes.
It's finally produced. See, there's a difference. There's a production area, which is with the nephrologist, and then there's a drainage area, which is with the urologist.
Yes.
All right. So the drainage area is where you pick up from.
That's where we pick up from, because once it's produced, it must get to the outside world. And so it deals with also the pediatric urologists will deal with those areas that relate to the urinary tract, particularly in relation to malformations, like my colleague has talked about. A lot of children will be born with malformations, so they deal with that. As adults, we deal with those issues that develop in adults as they are, mainly related to how the urinary tract is drained. Yeah.
Fantastic. Now we want to also drill deeper and look at the menace of cancer, just to pick up on one particular issue that is really ravaging, and I know maybe we can also learn experientially from India, because the cancer-related cases that we have in the country and India, medical studies shows that a lot of Indians don't really have, or they're not really ravaged by cancer. Could it be the case of a dietary, regime that they have that we do not have, or what could be the difference? Because they say a lot of medical researchers also say that basically the fact that you use a lot of spices and turmeric is one dominant part of your diet as well, and it has got that medicinal value that's sort of fend off those carcinogenic cells. You will tell us about this, but just overview, if you can give us an overarching overlook on how cancer is in India and how cancer in Kenya is, what will be the picture, Dr. Zipporah?
Okay, I can't talk about India because I don't know about India, but for Kenya, yes, cancer is increasing, just like other non-communicable diseases. Whether it's increasing or whether we are becoming more aware, it still remains to be, I don't know exactly what is going on, but we do have more cancer cases in the country these days. And I think mainly it's because we've had a lot of awareness, public awareness, people are becoming aware of symptoms or early symptoms and are going to see doctors. And also our lifestyles have changed. I think we used to have a lot of physical activity, we ate a lot of vegetables before, a lot of natural foods, but now, especially in the urban areas, people are eating a lot of processed foods. That is also a risk factor. And of course, lifestyles that include things like smoking and taking excessive alcohol are also things that are impacting on the cases, the incidence of cancer these days. So there are a lot of factors that are really part of what is making cancer more common in the country, whether it's childhood cancer. Well, childhood cancer are not related to lifestyles mostly, but adult cancers are related to lifestyles. So we have increasing numbers of cancer patients, diabetes, hypertension, other diseases as well. So it's lifestyle plus, of course, the genetic part of it is there, but I think a lot of our current lifestyles are really impacting on our health.
On the health issue, right. Okay, we want now to give you a chance also to tell us what you're telling us more broadly on the lectin. And I think we'll begin with you, Professor Mungai Ngugi. Yes. You have the lectin there, so you have your mic as well. Right. So you'll just remove your mic and put it at the back of your seat as you walk over to the lectin. And you have your camera, that is camera 3. You'll be speaking to that camera, addressing the nation for 5 minutes. Yeah, sure, you can pass through here. And we have Peter Mungai Ngugi, who is a urologist, also is Associate Professor, Department of Surgery, University of Nairobi, and also is a consultant surgeon and urologist at Kenyatta National Hospital. It is 5:50. We'll take 5 minutes beginning now, and then we'll take a short break. Just talk to Kenya.
Thanks, Dibal. I suppose one of the reasons why I'm here is to talk about prostate cancer. And prostate cancer is a very common illness in this country. Prostate cancer affects that part of the drainage of the urinary tract that is below the bladder, through which the urethra passes. Prostate cancer is a very common disease worldwide, but particularly common amongst people of black extraction. Amongst Africans, black has the highest incidence. This has been shown world over. In Kenya in particular, prostate cancer will affect 1 in about 10 men in their lifetime. And the problem is not in affecting so many, but how it presents in this country. 78% of Kenyans will present with metastatic prostate cancer. The metastatic prostate cancer is disease which has already spread beyond the confines of the prostate. This means that this cancer can only be mitigated against, can only be treated, but you cannot cure this cancer. Once cancer has spread out of the prostate, like any other cancer, once it has spread out of the organ, the cancer will ultimately kill the person who harbors this cancer. For that reason, once diagnosed with prostate cancer, you are likely to die from that prostate cancer. The rest of the world, the developed world, treats early prostate cancer. And I suppose my colleagues from Apollo would be probably more familiar with treating the early prostate cancer. The early prostate cancer is disease that you see before it has clinically manifest. And at that time, when you have disease which has not clinically manifest, you can get rid of it by various ways. You can get rid of it by surgery, complete extirpation of the same. With improvement in care of patients today, we have treatment options like brachytherapy, where you're actually going to implant seeds of radioactive material onto the cancer, a targeted cancer. This has only been recently introduced in Kenya, probably about 2 months ago, where you can actually get rid of the cancer without having to cut the patient and go and look for it. Once that is gone, you can also give targeted radiotherapy from the outside, and that too can cure patients. But you can also, science has shown that surgery is one of the best ways of getting rid of prostate cancer. You can, once you have diagnosed it, remove the entire prostate, and this patient will die, like we all will, but not from prostate cancer. This has been one of the problems in this country, in that we are not able to access patients when they have early prostate cancer. The majority, like I said, 78% of them will present late. Even when they present with locally advanced prostate cancer, not everyone is able to access the treatment that is required for this. So a lot of the patients end up not getting treatment at that point. And they present at late stages of the prostate cancer, when now it has metastasized all over the body and when life is short. For instance, we know if the disease reaches bone, your life expectancy will be below 5 years. This was discovered 20 years ago. So the majority of our patients with prostate cancer will die within 5 years. And this is because they were not able to access care. The care that should be given is one of being able to tell that people have prostate cancer. Our men are not used to going to hospitals. Our men typically go to hospital the time when they have a symptom, and usually 1 to 2 years after their symptoms started. So by this time, the disease has spread, and the treatment you'll give will give them the treatment, yes, but the treatment is not as good as what they would have gotten 2 to 3 years before. So what should we and Kenya do? Kenyans should strive to present to clinicians when they have any symptoms, particularly the symptoms that relate to the urinary tract, particularly that relates to the flow of urine. When you find that the flow of urine has changed, you should. But even better for those who really want to take care of themselves is doing the test called the PSA. If you do a PSA between the ages of 45 and 54 years, you don't have to do it annually. Now it has been shown. You just need to do once between the ages of 45 and 54 years. And if you have a raised PSA, we look for prostate cancer and we can be able to take care of it. If you don't have a PSA within that period, you'll probably present to us with symptoms, and then if you have symptoms, you will most probably die from that prostate cancer. We must be careful and we must go for treatment when required. Thank you.
Thank you. Thank you, Professor Mungai Ngugi there. And of course, it's very, very important that you seek medical attention early. And of course, you have also a full body checkup regularly so that you don't get surprised by this maybe benign or also some terminal illness like cancer that you'll find maybe has actually degenerated into the late stages. And we have Dr. G.K Jadhav from India, who is a radiation oncologist, Department of Institutes of Cancer. Of course, this is from Indraprastha Apollo Hospital, New Delhi. He is an MBBS, MD, DMRT, DNB, MNMS, and of course, he's a fellowship. The fellowships and membership, you can also see them they put there for you. UICC Fellowship, Commonwealth Fellowship to UK, and the list goes on, and is here to talk to us on cancer and palliative care, and of course to give us an experience from India as well. You have 5 minutes beginning now.
Thank you, Devil. Good morning, viewers. Today I'm here to speak briefly on what is the importance of cancer screening particularly, because of the 3 areas in cancer. We have cancer screening, cancer diagnosis, and cancer treatment. Now, the most important part that separates developed countries from the developing countries is the screening portion. Most of the developed countries go for what is called as a screening program, which is annual checkups, both in males and females. This detects cancers in early stages, where these patients are caught in a very early stage, and these are in almost a curable stage of life. These are 100% curable, you can say. Earlier, the better. The annual checkups for males and females, like males, you have a PSA plus a full body checkup, including of a chest X-ray and ultrasound abdomen and a blood profile. Similarly, in females, you have a blood profile, you have ultrasound abdomen, pap smears, and bilateral mammography. Plus, if you have any symptoms like a lump or a pain or anything, you can always tell the doctor when you come for the screening, so that more focus is given to that area during the screening period. Once screened, the diagnosis is made, I think then the treatment becomes much easier for the treating clinician. Diagnosis we have, particularly I'm talking about India now, when we talk about diagnosis in most of the developed countries or in India, we have state-of-the-art technologies like the CT scan and MRI scan, which I'm sure are available in Kenya, which I know that. But what is added on to this is a PET scan. Now, PET scan is the one which can pick up a cancer at a very early stage, or also can tell you about its manifestation as a metastatic cancer in other areas. So the clinician can plan the treatment according to the staging of the disease. When it comes to treatment, you can either, you have the surgeon doing the surgical oncologist role, or the radiation oncologist treating the primary tumors and the metastasis, and then you have the medical oncologist giving chemotherapies. Now, the chemotherapies may include even immunotherapy or targeted therapies, and at the end we will also have what is called as a bone marrow transplant. So all these facilities are available in India, but I think Kenya is about to catch up with that, and I'm sure we can do that here. And regarding the diagnosis of a cancer and a patient suffering from cancer, this is more of a, not only a family issue, personal issue and a family issue, it's also a social issue and a national issue. There's a lot of funds being wasted, or rather spent, on the treatment of these patients. A lot of social time is taken up, or the family time is taken up in the management of these patients. Like the attendants miss the work, there's nobody at the work office. So all these are, what you call a chain of events which can happen in a family. So just the patient doesn't suffer, the family suffers, the society in general suffers, and in general the whole nation is involved in this. So my take-home message is, early screening is the most important part, which can detect a cancer early, in early stages, make you more curable, and then give you a good quality of life in the remaining days.
Thank you, Dr. G.K. Jadhav there from India, and he's a radiation oncologist. And of course, he is warning you and advising you that early screening is the most important part of battling cancer. So he's enumerated for you some of the tests that you need to do the rigors of them, blood profiling as well, pap smear, and the rest that we'll be discussing here. So have you been screened, right? And if also you have been screened, do you go for also, you know, other rigorous checks during the year, right? So early screening is very important. Up next, we will hear from Dr. Zipporah Ali. She'll walk up to the podium and just give us and paint a picture of what is really happening in our country as well. She is the Executive Director of Kenya Hospices and Palliative Care Association. Also, she is a board member of Hope for Cancer Kids International, Children's Palliative Care Network, Worldwide Palliative Care Alliance, and Hospice and Youth Against Cancer in Kenya. And she is also a stalwart of fighting for the rights of children, especially who are ailing with cancer. And she is involved in advocacy and creating awareness on pain relief and palliative care in Kenya for children and adults. She holds an MD from EGE University, Izmir, Turkey, a master's degree in public health from the University of Nairobi, a higher diploma in palliative care from Oxford Brookes University, and a master's in palliative care from the University of Dundee. And she has completed also the International Pain Policy Fellow Program with the International Pain Policy Studies Group. Dr. Zipporah, you have 5 minutes, beginning now.
Thank you very much. Good morning, viewers. As you've been told, actually I work in the field of palliative care. I work with the Kenya Hospices and Palliative Care Association, which is the umbrella body for hospice and palliative care in the country. And earlier on I explained what palliative care is, and I'll try to again talk about palliative care, because I think a lot of times we have a very big misconception on what palliative care is. WHO defines palliative care as a service that is given to people with life-threatening illnesses, including cancer, that usually we talk about life-threatening or sometimes life-limiting and sometimes terminal illness, because people do die, as Professor said, that sometimes we get to the doctor when it's very late. So palliative care focuses on the quality of life, on improving the quality of life of the patients, and it goes beyond the quality of life of the patient and also focuses on the patient's family, because cancer, like I said earlier on, is very devastating. Any chronic illness is actually devastating in a family, psychologically, emotionally, spiritually, and financially. So we address all these issues in a patient. And maybe if I just emphasize, for example, prostate cancer, and it is now a topic of this morning, patients with prostate cancer will come with advanced disease in this country, and they'll have a lot of pain, mostly bone pain, because that's the most common complication of cancer that has spread. So this pain has to be treated. And if you don't have special knowledge and skills in treating this pain, you might not be able to alleviate the patient's pain, which means they live in a very miserable way with pain and suffering. They might come with issues, for example, for weight loss, anemia, and even just fatigue is very, very common with prostate cancer patients. So we address this kind of symptoms. But apart from that, what does a cancer diagnosis do to a patient? I think you've seen the campaigns that have gone on in this country for some time. People say cancer is a death sentence, because most of our cancer patients actually die within 1 or 2 years of diagnosis, because they come when it's very late. But I want to say cancer is not a death sentence. Like Prof said earlier on, and the other doctors from India, if you make an early diagnosis and treat the patient, they can live. And if they're not even able to live, to be cured, the palliative care is supposed to support them until whatever the end of the disease is going to be. So palliative care focuses on the quality of life. It's not just for adults, it's for patients, it's for children as well who have got even disabilities and congenital illnesses. And also, I want to also say that our country actually is doing a lot in terms of palliative care. Our government, Ministry of Health, has actually made palliative care a human right in this country. Our patient charter talks about Kenyans' access to preventive, promotive, curative, rehabilitative, reproductive, and palliative care services. Although I think they need to include mental care as well, mental health as well. So it is now a right in this country to demand for your palliative care services, for pain relief, for counseling, for spiritual care. And I want to also say that palliative care cannot be given by one person. It's a team effort. The doctors, the nurses, the pharmacists, the social workers, the chaplain, the caregivers, the family are all part of this service. So it is important that we actually have palliative care integrated in our healthcare system. We've been working with the public hospitals to integrate palliative care in the public hospitals. We have, I think, about 30 county hospitals that are doing very well. And our focus in the next 2 years to reach those hard-to-reach areas, for example, in the northeastern Kenya, where there's no palliative care at all, to be able to have access to palliative care for those patients in those countries. And again, of course, in palliative care, we talk about access to pain management. And this means use of opioids. drugs like morphine or medicines, let me not say drugs, medicines like morphine that control pain. And I also want to say that in terms of morphine availability in this country, there has been a lot that has been going on. The Ministry of Health is actually now providing the morphine for public hospitals, which is something that's very new, that was not there before. And so we are really focusing on advocacy, on awareness, and increasing access to services, palliative care services at all healthcare levels, systems, whether it's public, mission, private. Actually, they should put palliative care into their systems. And in our National Cancer Control Strategy, it's actually one of the strategies that palliative care should be available to every patient who needs it. Thank you.
Ali, who is the Executive Director of Kenya Hospices and Palliative Care. Right, we shall hear also from Dr. Sanjiv Jasuja. He's a nephrologist, and if you joined us or you started with us at the top of the hour, also he defined who a nephrologist is. He'll walk to the podium right now. He also is from the Apollo Hospitals from New Delhi, and he is a member also of Indian Society of Nephrology, Indian Society of Organ Transplant, Indian Society of Critical Care, Indian Society of Clinical Research, International Society of Nephrology, also European Dialysis and Transplant Society. You have 5 minutes, Dr. Jasuja, beginning now.
Thank you. Good morning to Kenyans. Before I start my talk, 1 minute, I'll just give you the update details that why we are in today, particularly in Nairobi. We are setting up an Apollo Information Center, which is going to be somewhere in the heart of your city, and that will be giving the information to the entire of the Kenyan population pertaining to the health disorders where they're seeking some kind of assistance from healthcare in India. Now, why it is needed in your country and with this kind of arrangement, why we had come up with, for last 2.5 decades, we've been serving to our neighboring countries in terms of healthcare. And globally, if you see the healthcare hubs, they're largely confined to either to the West, and equivalent kind of a hub has been created in our country. Fortunately, in India, the medical healthcare is very well developed, and it's nowhere lacking as compared to the Western counterpart of ours. And because of that, we are able to suffice not only our needs, we've been able to cater to the surrounding vicinity. And for the last about couple of years, we've started moving into the continents where we can support the population or emerging economies who are lacking that kind of particular facilities. We are taking care of their patients. So in that context, now this is an information center which will also have a telemedicine center which can provide you the brief interactions to the doctors before going there, meeting them, discussing your problems, and probably it will sort out a lot of your issues. And another important thing is our cost of the healthcare which is provided at India is roughly about 1/10 the cost which you have to bear in the Western world. Like in my subspecialty of nephrology, where we are doing a kidney transplant, the cost of transplant is not more than $9,000 to $10,000. So that's and if you look at the Western world, it's fairly higher as compared to this. Now, coming to my subspecialty, now I deal largely with kidney transplants, dialysis, peritoneal dialysis, primary disorders of kidney, and in the field of transplant, we have really made a big headway. We are doing first transplant, second transplant, all immunological workup on these patients. We are also giving highly immunologically challenged transplant, particularly many a time in women who had multiple partners or who had a previous failed transplants, multiple pregnancies. They become a difficult area to transplant, and we have evolved expertise to give them a transplant. But one caution I would give you, in our country, we are doing purely a related transplant, so we are always looking for a donor from within the family framework who should be altruistic donor. So that kind of a transplant program is very successfully being run in our country. And additional, for last about half a decade, just to increase our donor pool from within the family, the basic requirement of a transplant had always been a blood group matching. But now we have overcome that requirement as well. We can give ABU incompatible transplant. If you have a family donor who doesn't have the same blood group as the patient, or the person has a blood group which is different than the patient, or not having the O blood group, which is a universal donor, we still can perform a transplant on this. Now, this requires a high skill kind of arrangement or some procedural interventions which are carried out on a patient, and we offer them a successful kidney transplant. And going to dialysis care, we are well versed with what kind of option modalities particularly is required for a chronic care patient, and in for the patients who are staying far away from the hospitals, we can offer them peritoneal dialysis if the option of dialysis is not available. And in primary disorders, we have all kind of histological assessment gradings with us available. We do light microscopies, we do immunofluorescence studies on all histologies, we do electron microscopic studies to get into the more details about the problems which one carries. Now, why we take all this is because the emerging economies like India or Kenya, we have very high incidence of chronic kidney disease. And the incidence is to the tune of roughly about, I would say, about 200 to 300 patients per million population. Now you can calculate what is the prevalence in your country. It's almost going to be a very mammoth task for the governments to fund these kind of key areas. So that's why it's better to have some kind of preventive healthcare in the kidney disorders also. So if you have a diabetes, you have a blood pressure, or the family member who is suffering from any kind of kidney disease, please follow your doctors and follow it very diligently. Thank you.
Dr. Sanjiv Jasuja there, giving us also the lowdowns on nephrology, what it entails, and of course, if you have kidney complications, it's talked about transplants as well, dialysis also, which really incurs a lot of cost when it comes to medical care as well. Lastly, we're going to hear from Dr. Sujit Chowdhary. He is a pediatric urologist and a pediatric surgeon from Indraprastha Apollo Hospitals, New Delhi. Also, he is a MBBS, DNB, MS, MCH, FRCH. Right? He's from member also of International Pediatric Nephrology Association, European Society of Pediatric Urology, American College of Surgeons, also American Academy of Pediatrics, also Association of British Scholars, I should say. He's gotten also awards as well from the British Council Specialist Clinical Fellowship in Pediatric Urology and at Great Ormond Street Hospital for Children. That was in 2001. You have 5 minutes.
Thank you. And good morning, everybody. I had an interesting conversation with Professor Amgai just before coming here to talk to you, and I heard from him that urology is a well-developed specialty in your country, and I also heard from him while he was talking about the delayed diagnosis. So if you look at Kenya and India,
if you might just adjust the microphone a bit so that, yes, we can hear.
So if you look at Kenya and India, we are very similar. We both were ruled by the British, who gave us our basic medical infrastructure, and we became independent in 1947, and you became independent sometime in early 60s. So our social and economic development is following a trajectory which every developing nation follows. So the problems my colleagues here from Kenya were talking about is the problems that we were dealing with 15, 20 years ago. I remember I trained initially in the 80s in India's premier teaching university hospital, where our results in the adult surgery were almost neck to neck with England. But when it came to surgery of the newborns and surgery of children, only 50% of newborns would survive after surgery. And the children, endoscopic surgery was out of the question. And if a child was operated for tumors, then the tumors would promptly come back because the chemotherapy was poorly developed and radiotherapy was hardly there for small babies. So what has changed? What has changed is that India is today able to offer nearly what London can offer, or Boston can offer, or Melbourne can offer to a child with complex diseases. Complex diseases meaning disease or surgical conditions which require multiple specialists to work together in association with a surgeon to provide not only surgery being done on a child, but surgery to have successful outcome in the long run. So if you look at a child compared to an adult, he has got 90 years to live, unlike an adult who has a coronary artery bypass at 70 years or 65 years, where the surgeon's skill and surgeon's work is tested only for 5 years or 10 years. So the third thing, kidney, since my main work is pediatric urology, kidney is a silent killer. We don't have kidney attacks, unlike heart attacks. So since kidney is a silent killer, majority of children grow up with urological conditions to then end up with chronic renal failure and then head towards renal transplant. And if you look at a very interesting data, 1,000 kids were evaluated in Italy and 1,000 in All India Institute in Delhi. And out of the 1,000 in All India Institute in Delhi, 30% kids had preventable condition where the chronic renal failure should not have happened, whereas in Italy only 3% children had chronic renal failure secondary to obstruction in the urinary tract. So the first problem is, how do we diagnose these conditions in children? Because a child doesn't have any symptom, whereas he can have obstruction to his urinary tract with mild symptoms of infection or which may get missed out. So, like the cancer work, I think in the pediatric world, what should be made very, very popular in countries like Kenya, as also in India, is a random ultrasound with the mildest symptoms in the abdomen. So if you have a child and you have a son or a daughter who complains of non-specific pain abdomen, I don't know how expensive ultrasound is in your country, but in our country it's very cheap, it's very widely available. So everyone should go for a screening ultrasound with the mildest symptom a child has. And whenever a child has fever, he should go for urine routine examination and culture to detect if there's infection. And a combination of basic ultrasound and urine routine examination should detect whether you have any serious condition in the abdomen. Then comes the question of consultation. That is where the role of Apollo Information Center comes. You have very well-trained urologists and pediatric surgeons in Nairobi. I've met some of them. But we are available here with you for a telephonic consult. This is the time of digital consult. So without any worries about financial implication, every mother is free to consult us on the email, and we'll help you all. Thank you.
Thank you. Thank you, Dr. Sujit there.